Rahim. Uh, I am Professor Mohammad Yakoob Ahmadani from Pakistan, and I will be presenting my data on clinical validity of new risk scoring system, Pakistani data. As we know that the prevalence of diabetes in the Muslim population is rising, and a significant proportion fast during the month of Ramadan. Estimates suggest that there are over 150 million Muslims with diabetes worldwide, and almost 160 million people may choose to fast during Ramadan. And as you can see that against the global average rise of 46%, the rise in the sub-Saharan Africa, MENA, and Southeast Asia is tremendous. So in the next 25 years, the number of adults with diabetes will be in Muslim majority regions, and of course, these people fast during the month of Ramadan. For pre-Ramadan assessment, the risk stratification is an important part of our managing these people with diabetes. And to stratify the risk, we have an individualized management plan for them. During a pre-Ramadan visit, a detailed medical history should be taken, along with other aspects of diabetes ability of self-management, looking into the comorbidities like kidney disease, like heart disease is very important. And of course, the prior Ramadan fasting experience is also important. And the personal circumstances of individual, whether he lives alone or he lives with somebody, whether he monitors his or her sugar or not, depending upon the conditions. And these patients should be seen 6 to 8 weeks before Ramadan. Previous diabetes and Ramadan guidelines in 2016, they have proposed risk categories to stratify people with diabetes who wants to fast. They were categorized into high, very high, and low to moderate risk categories. But these categories were based on expert opinion and not on evidence. Recently, IDF DAR Practical Guidelines 2021 adopted a scoring system considering various factors that were deemed to influence fasting, again based on experts' opinion. This was the scoring system, where you have different elements, around 12 and more than 12 or 14 elements, where you classify people based on these different parameters, scoring them if they are score between 0 to 3, lower risk, if they are between 3.5 to 6, moderate risk, and if they are more than 6, then they are at higher risk. For a given individual, each risk element should be measured, and then the total should be made to know whether they are in low, middle, or high risk. The resulting score will determine the overall risk level for an individual who is seeking to fast during Ramadan. Hence, this study was designed to check the clinical validity of IDF DAR risk elements for risk calculation and the relevant scoring among fasting people with diabetes during Ramadan. It was a prospective observational study. Study site was Bakai Institute of Diabetology and Endocrinology, and the ethical board reviewed the proposal and given the consent for the study. The study was done between March and May 2021. The sample size was 953. People with diabetes who intend to fast during Ramadan were recruited during the pre-Ramadan period, and the patients who are not willing to fast or are critically ill were excluded. Minor hypoglycemia was defined as blood sugar reading of less than 70 milligrams per deciliter. Major hypoglycemia was defined as less than 40 milligrams per deciliter. Minor hypoglycemia was anything more than 200 milligrams per deciliter. And if it is more than 300 milligrams per deciliter, it was considered as major hyperglycemia. During a pre-Ramadan visit, consent was taken, as structured education was given, and the risk score was calculated based on the score which I have described earlier, and the demographic data was also noted. Fasting status was noted out in the post-Ramadan visit, and the assessment of complications during Ramadan were also made in the post-Ramadan visit. And this statistical package of social sciences version 20 was used to compute mean, standard deviation, and percentages. And there were 48% of males and 51% of females. The mean age was 49.2 years. The mean BMI was 28.9 kilogram per meter square. There were 90% with type 2 diabetes and 9.9% with type 1 diabetes. The duration of diabetes in 67% of the people was less than 10 years, while in 32.4%, it was more than 10 years. On the basis of risk score, 56.9% had a low risk score, and 16% had high risk score. So combining moderate and high risk scores, there were 42 or 43% of people who are at moderate or high risk. And the number of days, although it was less in high risk category, the whole month, there are 73% of the people with high risk score fasted, while 87% of the people in low to moderate risk scores. And the major complications we had mostly in people with high risk, major hypoglycemia, major hyperglycemia, and also the breaking of fast was also seen mostly in people with high risk scores. There were those who had complications and those who didn't get complications. Looking into the different parameters there in the risk score, the risk elements, significant differences were found. Although the complications rate was very low, only 80 patients got complications out of 953 patients. So the risk overall, the complication rate was very low. However, different factors looking into the different risk elements, we found significant differences, like people who had type 1 diabetes, they got more complications, 48% against 6.3% who didn't get complications. And people who had a history of more than 10 years had more complications. And similarly, the history of hypoglycemia, people with poor glycemic control had more complications as compared to people who had less good glycemic control. And regarding other elements like SMBG and acute complications in the risk score, the elements EGFR, they were not significantly different, but in the chronic complications, the presence of chronic complications, also there were significant differences in people who got complications and those who didn't get complications. There were not significant number in the other risk elements like pregnancy, frailty, and cognitive functions. Physical labor similarly, and there were not significant differences in the previous Ramadan experiences between those who got complications and those who didn't get complications. Similarly, treatment-wise, also not much differences. Slight differences were there. People who were on there were differences, but because of we did a regression analysis on this, these different risk elements and looking into these risk elements and the risk of fasting, like complication rate, we found that only two of the factors, that is the type of diabetes, type 1 diabetes had more risk than more complications than people with type 2 diabetes. So 8.3 times more in people who had type 1 diabetes. The other risk element was on regression analysis was found as CKD, and the CKD people had more complications compared to people who had no CKD. So these were the only two risk elements which were found to be significant in people who got complications. So in conclusion, we can say that the overall complication rate was low and majority of the people fasted safely during Ramadan. People with high score got more complication as compared to people with low risk scores. Among people with moderate to high risk scores, only type 1 and presence of chronic kidney disease were found to be significant risk elements. So the risk score is not predicting complication in each and every patient. We can say that people with moderate to high risk scores, and if they have type 1 diabetes or CKD, they are at more risk, and further studies are needed to validate our findings. I thank you for your attention.